Welcome to the webinar on Dialogue on Misconceptions, Dichotomies and Flaws of COVID-19 Pandemic. Are they still inexplicable? This webinar is organized by Committee for the Popularization of Science together with Section A of Sri Lanka Association for the Advancement of Science. So before commencing the webinar, dear participants, there will be a question and answer session at the end of webinar session. So please post your question to the Zoom chat box. And also, if time allows, at the end of the session, you will get the chance to ask the questions from the resource person directly. It is my great honor to introduce our resource person, Professor Manuj Weerasinghe, President-elect of Sri Lanka Association for the Advancement of Science. Professor Manuj Weerasinghe is a consultant community physician and currently serves as the head of the Department of Community Medicine, University of Colombo. Professor Weerasinghe obtained MBBS, MSc in Community Medicine, and MD in Community Medicine from University of Colombo. He also completed a fellowship at University of Pittsburgh, USA on health policy and health program evaluation. Professor Weerasinghe has done research on health-seeking behavior in marginalized groups, pharmaceutical utilization, evaluations of public health programs, and adolescents' health. And today's webinar will be moderated by Professor Mahesh Jaiveera. Dr. Jaiveera is a professor in environmental engineering at the University of Moratuwa. He is also a corporate member of Institute of Engineers, Sri Lanka. Professor Jaiveera obtained his BSc degree in civil engineering from University of Moratuwa and PhD in environmental engineering from Saitama University, Japan. Professor Jaiveera has been engaged in different environmental tasks for more than 30 years and presently serves as the chair of Committee for the Popularization of Science of Sri Lanka Association for the Advancement of Science. Professor Jaiveera, over to you, sir.
Thank you very much, Jayangika, and thank you for all those who joined. Ladies and gentlemen, ever since the detection of COVID-19 virus, or we call it SARS-CoV-2, in late 2019, our day-to-day lifestyles have been changing dramatically. As of today, we observe more than 3.5 million deaths globally, and the mortality rates have been very unpredictable, perhaps with the emergence of new variants of concerns. To this end, many have been working around the clock on different facets of COVID-19 pandemic. To name few: virology, disease pathogenesis, epidemiology, clinical features, diagnosis, non-pharmaceutical management, and vaccine development, among others. My dear colleagues, ladies and gentlemen, from today's perspective, we are indeed in a precarious situation where we are still struggling to conquer this virus. In such efforts, one needs to comprehend new evidence-based knowledge to eradicate this menace globally. It is true that we do collect a myriad of information on COVID-19 via many modes of communication. However, we most of the time speculate such information as they may not be accurate and authentic. Hence, in this evening, we have organized a dialogue on misconceptions, dichotomies, and flows of COVID-19 pandemic with a view to giving you clear and evidence-based clarifications whenever possible. I just want to put this within brackets, whenever possible, because it may not be possible for every query that we raise. For this gigantic endeavor, we have here with us Professor Manuj Weerasinghe, who is an advocate and a scholar in this area of specializations. Good evening, Professor Manuj. Good evening, Professor Manuj. Professor Manuj?
Yeah, sure.
Today, I have lined up 20 queries that I believe the general public needs to know or to demystify. I hope you could explain us all of them in a conceivable manner. Let us start with one by one. The first query that I would like to ask you is, people believe that the SARS-CoV-2 is a man-made virus than a natural with a zoonotic origin. Do you endorse this statement, or do you have a different opinion? What evidence do you take on board when you elaborate your opinion? Over to you, sir.
Thank you, Professor Jayavira. And it's good that SLAAS organized this webinar, which is very clearly structured, where most of us want certain answers to certain questions. But before going back directly into the question that you posed, can I have 2 minutes to explain certain things, because this is a scientific forum and there are, I understand, beyond scientific forum, other beyond SLAAS membership, there are others who will be listening. So from my side, what I have to tell is, and I have been telling on communication, of science communication, has 3 different levels. First one is that when there is an issue like this happens within the scientific community, within the technical community, who would be called to discuss something, and in the implementation arm of that, there will be serious discussions where different evidence, different thoughts and others are discussed, and at that forum different people will express different things from different evidences, and that is where that type of discussion happens. And I personally feel that is the forum for that type of discussion. Then from there, for policy level, there will be another forum where some of the recommendations, options brought from this scientific forum be articulated into policy level recommendations for the decision makers to take. So at that level, a certain amount and certain level of discussion and expression will go up. But beyond that, there is another level, as what we are having today, primarily of making aware other scientists and general public basically on matters that they should know actually for the control or for face the challenges that we meet at this particular point in time. Therefore, in this forum, I will be touching some on the technical issues, but my main concern when I'm going public on those, that I will be mostly restrict myself to the awareness component of people, which is the duty as professionals when we look at mass media and science communication to that particular level. So I would very clearly state this, because what we find in most of the media is unnecessary political discussions been coming at mass media level, which makes people more confusing, and we keep more question marks on their head for people who are going to sleep, and not really clearing question marks that we need to do as professionals. So I would just want to tell that at the beginning. So the most interesting question, which maybe million or maybe $10 million question, which came from the very beginning when it came out of Wuhan and when it is kind of spread. I think I will have not going to elaborate mostly on this, but there are 2 schools of thoughts. One is that it is done within a lab. Second one is it is a naturally occurring virus which has had some change in their mutation or whatever, and now the human become the host. So these are the 2 I think that schools of thoughts which is behind this. And if I just elaborate on this, when it came out of Wuhan, there was so much of, I think it's almost 1 year, but there was so much of discussion, particularly in news media, than in scientific level, looking at our general understanding on scientific fiction and movies also, which has been predated to this event. Some of the movies have gone up to beyond, I think, 2009, 10, that similar things have been seen about 10 years back. So that also gave some fuel to people to think that this is a laboratory-derived one. Secondly, there was some, I would rather say, a global politics involved in this articulating, where people would say that it came from Wuhan, where one of the, I think, primary labs of virology is located. And all these are finally covered by large amount of externalities beyond virology and public health. Therefore, my personal reaction to what the first question or whatever the issue that I think, I don't think there is any evidence up to now which is proved or could be proven that it came from a lab. If you look at all the scientific or other things that have been written, mainly commentaries type of thing which appeared or news items would basically come and tell that it is a laboratory thing. But when the WHO went there, when others went there, when others checked it, but there has not been much evidence to show that this is a laboratory derived organism. So that is where I think is the main issue lays. I personally don't think there will be an answer to this. There will be people who are going to prove it, and there will be people who are going to disprove it. Scientific community will be also divided on this, and this will be a continuing debate. And the conspiracy theory is something which is going to next millennium also. That is what I want to tell. But there is an important message that we have to take. Our prime duty as professional scientists and public at this moment is to do our best to control the epidemic that is going and the pandemic going across the world. And just debating and actually wasting our resources, whether it's laboratory or whether it's nature, is not going to help us in facing this issue at the moment. Now it has gone beyond whatever. So I think our main message to, if it is a public, is we should not distract our focus from preventing this further spread of disease and to get out of this mess as quickly as possible, and not going through sidewalks as they open gates for us to walk in.
Thank you. It's very clear. But I just want to, just check with you. Now, since the DNA of this virus has been disclosed, now can't you, go date back, or maybe to go into the lineages to identify the most probable origin, let's say kind of a bat or any sort of animal? Would you be able to, just elaborate on us whether it is possible for us to identify zoonotic?
Actually, these are RNA viruses. It's not DNA, it's RNA viruses. Second one I want to tell is I am not an expert on virology and genetic sequence. So what my personal understanding is that one would go and have some hypothesis to do it. But now at the moment, genome sequencing is done basically to look at how we are going to prevent this mess going on, and what new variants and others would come, and what would be the forecast for the future. I think the resource on those laboratories are now basically put into supporting and supporting the control program.
Okay, thank you very much. The second query is basically for me to check the differences between the SARS-CoV-2 and the SARS-CoV. The question is, many believe that the SARS-CoV-2 is severe in terms of infectivity, transmissibility, and mortality compared to SARS-CoV. Are you in agreement with this statement? Could you present evidence supporting your answer?
Yeah, I think when SARS virus was first identified by one of our own Sri Lankans, Professor Malik Piris, in his Hong Kong laboratory, almost 15 years back. And at that time, I think it was a real threat at the very beginning when it was identified. and people were thinking that it would spread across the globe. There were few countries involved, but the amount of spread, amount of infectivity, and amount deaths that could be attributed to it never went, at least as a public health concerns of international concern, which means that it's spread across the globe. Its infectivity to do severe damage to make it as an epidemic in other countries, and the death toll was not so with that magnitude. But at the very beginning, when we saw it in Wuhan, there were analysis of two viruses by virologists, which I can remember almost appeared about 1 year back. They were comparing these two. At that particular time, it was said that the SARS, original SARS virus had more transmissibility than this. It was the original. Then there was another virus, if you can remember, it was the Middle Eastern or the MERS virus, which has more fatality than, as far as can remember, on SARS. But if you look at SARS-CoV-2, I don't need to overemphasize on what we are witnessing for last 1 year, particularly for last 6 to 7 months in across couple of countries. For example, when the epicenter moved from Wuhan to Europe, and Europe to then North America, then it went to South America. Now it has come to basically India and the South Asia. So if you look at the path it has gone, you could see how transmissible that virus across almost all the continents. But the death toll, even now, if you look at Brazil, the number of deaths that you can see, and now India, who has almost surpassed that. So I think this evidence is more than enough for us to look at in the aftermath of actually WHO. This is the first time that anyone is seeing such a devastation in the world.
Thank you. Yes. The third query is just to, about the transmission of this virus in the environment. It says there has been a school of thought that the SARS-CoV-2 is virulent depending on the favorable meteorological conditions, namely temperature, humidity, wind, etc. People try to summarize many episodes of high case numbers in cold weather or even noticeable geographical areas during specific period. Now, for example, these days, we can say we will see high numbers in countries like India, Sri Lanka, Bangladesh, Nepal, etc. in this particular region. What is the truth behind these statements? Do we have enough evidence to prove or disprove such beliefs?
I think if you look at the epidemic for 1 year and 5 months has gone from last December, last December means 2019 December, now June 2021. If you look at when it started and spread in Wuhan, it was midst of the winter. And people thought it would be restricted to China, and there were political, I think, issues coming from other Western and other certain countries where they thought that it will never go beyond the boundaries of China. Then in the early January and particularly February, look at still in the winter times, it invaded Europe and particularly the fate of Italy. It was winter time. And from winter in 2020, look at when it really jumped to US was in the spring. So it's a different type of environment, humid conditions. And if you look at New York and other states in US, and it was still part of winter, part of spring, but rather cold environment. So the first part of the episode or the pandemic was hitting the northern hemisphere during the winter and the early spring. But then look at what happened from US when it came to South America. It was directly tropical climate. Tropical climate and the humidity high Just look at what happened in parts of Amazon where the tribal groups were there, and still it's going and spreading. And from there, what happened in the next winter, we saw again a high increase in cases in Europe and even in US. And which means that whether it's winter, whether it's spring, whether it's summer, or whether it's fall, somewhere this was going from place to place. And now we know what's happening in India. India, it started is a late winter if you look at the top states of India, but if you look at Delhi, it was starting in a late winter period. Now it's summer. And in Sri Lanka, Bangladesh, and now we are having a bit of epidemic in Vietnam. And all countries, now it's real summer. And if you look at the humidity conditions across all these countries, it's a very varied type of humidity conditions, varied type of temperature, varied type of large land masses. And I think all geographical, I would rather say, landmarks is already invaded by this virus. So I think rather than looking at hypothesis, whether it's up or down, I think the general understanding, what we think is that it can go all across. And for that matter, as Prof. Javira mentioned, when we did have so little number of cases, so few number of cases last year, from about March to about June, we thought it's a thing that happens in winter. But if you look now, from October, we have gone that second wave, if you want to call it second wave, up to about mid-March, we don't have winter. Our temperature levels are generally from 78 to about 83 or 84. So it has spread, and now it's still spreading in India and Sri Lanka. Even Karnataka is now locked down for part of it. So look at this all. I personally don't feel that this is a virus that have much sensitivity for any of those, but it is going from person to person, and that's it.
Thank you. Yeah, it was very clear. The fourth, the query is on the, this particular virus being airborne. So many people, believe that this virus is airborne. The question is, many epidemiologists and virologists believe that the SARS-CoV-2 virus spreads in the environment by being airborne. The half-life of the virus in the air has been estimated to be 1.1 hours, which is very easily, we could be able to find nowadays. If this is true, having surgical masks will not serve the purpose because aerosol particles will penetrate through these masks. However, some do not agree with this notion. How do you elaborate this dichotomy with clear evidence?
Yeah, it's a very good question. First thing what we have to think about it, we are still learning about this disease and the virus and its spread. So science is something, as all of us know, which evolve, and view evidence when it comes, we need to accept those and work along those. So science is like that. When it first came, it was only people were looking that it is going through fish markets in certain parts of Wuhan, and later there was epidemic in a fish or actual livestock market in Beijing. So that is what the first impression. Then it was told that it is only by droplets, but the coronavirus is generally, what I understand, is large viruses, and therefore those things were discussed, and generally it was stated that it is through droplets and not so-called airborne mode. Why this whole question came up, I have two papers in my hand. One was published in Lancet on 15th of April, and the other one was published in BMJ and on 14th of April. First one is BMJ paper, second one is Lancet paper. Both are, one is editorial of BMJ, British Medical Journal, one of the most respected journals, And other one is Lancet, I think one of the oldest journals in this world on medical things. In 14th, I would rather say in BMJ, the editorial, I will quote, unquote, this is the editorial topic. It says, COVID-19 has redefined airborne transmission. So what they are talking in this editorial, the editors are talking that what is airborne transmission? And in infectious diseases and in medicine and those, they generally look at airborne is something which can transmit through air, particularly not for very short distances, but beyond a certain distance. And what they argue is, this argument, or whether it's droplet or airborne, is basically a theoretical argument on how to define the term airborne. And they are very clearly giving arguments stating that, so how we think these both schools of thoughts may be true based on the definition you use. And when it comes on 14th of April, the 15th of April, in Lancet, there's a commentary coming up. And it's a commentary. And difference between a commentary and a full research papers, most of us in scientific world understand very clearly. The commentaries are basically to argue out a reason based on a hypothesis that they have. So what this particular scientific commentary says, I will quote unquote the topic, 10 scientific reasons in support of airborne transmission of SARS-CoV-2. So what they say is that they argue out using 10 possible reasons that this is airborne. Mindful that we have to now look at what is airborne as suggested by the BMJ journal editors. So are we have an agreement now across what is airborne as a destination? I think that is the core to if we are going to answer this. And there is no consensus about any of these still in the scientific world as far as I understand. Therefore, we have to take these as arguments towards or airborne or still droplet infection. In these 10 arguments that they show, there are different, I would rather say, circumstantial evidence given to prove that it is airborne rather than direct evidence to show that it is tested and it is airborne and the person get infected. So all 10 points, I would ask, invite people who would be interested to read both editorial and this commentary. So what my final take up this is that I personally feel what you were stating on the surgical mask, we have certain precautions that we have used from around about in March or April last year, now about over 1 year. And there have been success stories of using surgical masks among physicians who are working in hospitals directly dealing with patients. And there are people who have done so much of aerosol generating procedures with surgical masks and later using N95 masks, which they have not got infected. This is my take home. And I know because I have been to IDH. I have been with Dr. Anand Vijay Vikrama one day, just 3 weeks back, ward to ward, just wearing a surgical mask to see some of the arrangement for what one of the hospitals we were trying to build. So what my general understanding, how they behave within a hospital, if they are not getting infected, one would say that this is not level 4 type of evidence. But my general thinking is that I think surgical mask for general public and N95 mask being used has pretty good cover against this if you use it in the prescribed manner. The issue comes here because most of us, whatever said and done, we don't use the mask in the correct manner. I am not going to go into detail, but if you look at most of us unconsciously touch the front part of the mask. When you want to have a tea or whatever, suddenly take it and put on the table, or we'll put in on our own pockets. And the issue is how we use it rather than whether it's effective or not. I think I would stop here. Thank you.
Thank you. Yeah, it was very clear. So the next question is very, very important. Everybody is conscious of this one, and we have been doing quite a lot of, this working, the practices of this nature. The question is, many say that immune boosting is a must against COVID-19. This topic has been trending in social media these days. To this end, people tend to go for Ayurvedic concoctions, fruit juices, vitamins, garlic, turmeric, lemon, zinc tablets, etc., 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 that have been flooded in the market in various forms. Is there a scientific truth behind these common practices?
It's one of the most sensitive questions one need to answer. That is one. Second one, it is one of the most controversial questions that nobody has been able to give a correct answer. And third one, if I am going to answer it, I will base my understanding on public health and the communicable disease epidemiology and the maybe somewhat knowledge on infectious diseases. What I understand is for any person, having a good immune system is good. I don't think there is any question about having a good immune system. But the issue is whether some of those taken drugs or whatever, certain preparations by indigenous practitioners or whatever, whether these can boost immunity. And to what extent have we proven that this will boost immunity? On the other hand, there is another question that I want to put into the table now. Will such practices would make people ignorant about their safety, thinking that they are now immune because they have taken some sort of remedies and others, because the conclusion or the advice given by some of them that you will be cured, you will have good immunity, and if you have it once or twice or thrice, that's end of the story for SARS virus. He will never come to you. And this is the problem that I am tackling from the other side. And on the other hand, I have been telling this for at least 10 years now. There are different scientific methods in different philosophies. The Western philosophy, we use a very clear scientific method that we think it is clear, and we have been practicing and we have learned it and we have put an objective way of proving it. But the particularly Eastern method or that epistemology has developed also in a way for centuries, and they think that they have their own way of doing it. I have no disagreement with other philosophies. I have it very clear. I have a huge respect to indigenous medicine and the Eastern philosophies. But my question comes here, in a public health emergency, if we are prescribing something and if we are advocating something, we have to be fairly confident in telling that this works. If we are going to tell this works. But in Western medicine up to now, I have not seen anything with so much of efforts gone within 1.5 years. Nobody said this definitely works. Even the vaccines, we give a margin of error. Even after the 2 doses that they are given, this is what we can prevent. Particularly all manufacturers, if you look at their leaflets and their real history, final take-home message is the vaccine will reduce severe disease and minimize deaths. So nobody claims even that it will 80% reduce the transmission. No. So when you are looking at others, suddenly person comes from, I think, as an alien and telling this works, I have done it. That level of science, unfortunately, we don't understand. And maybe they have some way of explaining it, but the general public with some scientific knowledge don't understand. Secondly, the way that they are portraying is bit question. This is going to be controversial, but I will tell you. Certainly people come that I am coming and giving some of a prescription which has been there for 9,000 years. But if you look at our history, do we have 9,000, 10,000 years ago in Sri Lanka, do we have a written or language that we can show this is the language that we have written 9,000 or 10,000 years ago, and how these so-called people have seen it? These are questions, marks that we have to ask. Secondly, one would say, I have done it. And there are certain deities or somebody has told it. So we have to think rationally to see, can a person suddenly come and tell that this is a prescription that we can use? And are we to accept it without scientific reasoning? So these are the things I think we need to look at. But there's a harm, as I told you. Because of this, when people are desperate for solutions, this is a very good playground for even people who have no understanding to earn money and exploit. So I think what's happening at the moment from popping up from different places is this phenomenon. And I think we need to be very clear in science. Sensational topics, sensational claims has to be taken with pinch of salt.
Thank you. Very clear, very clear. Yes, thank you. And the next question is more or less same to the earlier question. And it says, as a remedy to stem the transmission of SARS-CoV-2, people drink lukewarm or hot water, gargle with the same, inhale hot water vapors, or the same infusing herbals. And most of them now became habitual practice. Do these practices help avert the risk factors or aggravate the transmission? Or are people likely to have other physiological complications? Perhaps it may be irreversible. What is your opinion?
I think physical therapy to relieve symptoms of people have been used since ancient times. And people have been using it, particularly steam inhalation, and which gives a person a relief. And I think we need to be very clear about what a relief of symptoms versus curing of a disease. I think these are two things that we have to very clearly understand. Yes, even for those who are now in hospitals and others, because they have a respiratory infection and they find their difficulty in their throat, sore throat, and they have running nose and whatever the respiratory symptoms, having warm things is definitely going to ease their whatever the symptoms. But microbiologically, if a virus enters your body, it does not stay outside in your nasal pathway and go here and there. It will stick to a mucosal membrane and will get into a cell, and within the cell that it multiplies and give other viruses or copies of it to the rest. So if we can destroy a virus particle within a cell, then we have to first destroy the cell. So if we are going to have intense steam inhalation, then we would also destroy our respiratory epithelium of our trachea, and even some effects on your lungs. So this is what I really do not understand of this particular whatever the proposal, because if this thing can kill the virus, then it has to kill the thing which will have long-term effects if it is become a habitual. That is one. Second one, we saw in certain places in this country when there was so much of promotion of certain types of what I would say is steam and herbal steam and whatever. People buy one and few people use the same thing. And we know very clearly, I don't want to mention, huge clusters have taken place in this country because of that practice. So we need to be very clear. The next one is, this is warm water or whatever. There has been enough accidents when such a thing would topple on maybe a small kid or a elderly or whatever, and you need to be very careful about it. Then not SLAAS, he will be admitted with a burn, 2nd degree, 3rd degree burn injury. So this is what I want to tell. Thank you.
Thank you. Okay. So the next question is about a particular set of people in our society, pregnant women. The question says, pregnant women seems to be developing severe complications when contracted the COVID-19 disease compared to other ordinary people. Is this notion accurate? If so, what precautions do they adhere to? Over to you, sir.
I think it's an extremely serious concern that everyone has. From the new data that we are seeing, even in this country, from 14th of April, within last 1.5 months, we see increasing number of pregnant women getting infected. And we did not see such numbers in the previous 2 episodes. And the second one is, when they get infected, we see a substantial proportion of them getting severe disease. And you understand that at least I think now 6 deaths we record of pregnant women, which means that there is a serious issue. Particularly what we have seen, we call the pregnancy, we divide into 3 phases. First trimester, which is up to 12 weeks of conception, from 13 weeks up to 28 weeks, the second trimester, and the last trimester where till the delivery. What we have seen in this country also from unpublished data with the discussions, we have seen very clearly the severe effect is on the 3rd trimester. Last from 28 weeks up to 40 weeks. And some moderate or some problems in the 2nd trimester. And on top of that, those who have existing comorbid conditions, mothers, they are shown to have more severe illnesses. So it's a serious concern. There's no doubt about it. That is why there was a policy decision just 1 week back. Looking at all the data available, there's a policy decision taken by the highest body, which is the Communicable Diseases Advisory Committee, in policy that 2nd trimester and 3rd trimester, mothers who are high-risk mothers, there's a way of categorizing them, should be vaccinated. And that circular is coming out. And there was a committee appointed, and that committee has given their recommendations, and these things are being worked out now. Next issue is, how are we going to protect them? First thing, I think circular came almost 3 weeks back, or 4 weeks back, to keep pregnant working mothers home. I think that was one of the best things we could achieve very early. So we would restrict their movement and exposure. Secondly, we encourage them to attend the antenatal clinic, which is close to their home, and get checked. And there is a field service going on, which is the public health midwife. They will be actually trying and giving them advice. So these are the things which is done. Right.
Thank you. And the next question is about the rollout of vaccines. In Sri Lanka, the vaccination campaign for the general public against the COVID-19 virus has rolled out. Due to the shortage of dosages, 3 different vaccines, namely AstraZeneca, Sputnik, and Sinopharm, have been injected as the first dose. However, though some have got injected the first shot, the second dose seems to be not immediately available because of the sheer demand worldwide. From today's perspective, it appears that the same brand that has been injected as the first dose may not be possible as a second dose. People fear to have the mix, expecting health related consequences. Is there a truth behind this whole saga?
May I just tell the three vaccines which is used in Sri Lanka? First, we started with Covishield, which is AstraZeneca product from Serum Institute of India. Then we got Gamaleya Institute in Russia, which comes as Sputnik 5. And last, we approved Sinopharm from the Chinese vaccine from the Beijing Institute. It is nothing to do with so-called the brand. If you look at Covishield vaccine and the Sputnik vaccine, they are all viral vector vaccine, where they use a harmless virus and attach immunogenicity from this current virus, and they do from recombinant techniques, they make a separate type of virus which is harmless to us but could generate immunity. But in Sinopharm vaccine is killed or the inactivate vaccine of SARS-CoV-2. So these are three types of vaccine. And if you look at the base for Covishield is separate from the Sputnik 5, although both are viral vector vaccines. So Sputnik base is separate, different from Covishield, and Sinopharm is totally different. So that is the basis. So when Covishield vaccine was given for almost now 937,000 people, only about 340 or 50,000 has been given the second dose. So we have 100,000 people who are waiting for this. Original studies from the manufacturer, when it came, it was 4 weeks that they have to give the second dose. But the rest of the studies came later, showed no, the better immunogenicity will come around 12 weeks, and you could extend up to 16 weeks, the duration where you will get a better immunogenicity. So somehow, I am not going to get into why it is not available at the moment, but there is an issue that we have not stored the vaccine adequately to give for these 600,000. Now the current situation is like this. The current situation is there is still effort being done to get down 600,000 Covishield vaccine to Sri Lanka through different channels. And that attempt is still there. And what we think is, even if we can inject this by end of June, now we are in the first week of June, then we will still have adequate immune coverage taken for these people. So this effort is going. Secondly, if we fail to do it, there is a committee now appointed to look at what are the other options available. And one of the key options that is available, we know, study data is available, AstraZeneca with Pfizer vaccine. There is studies that will be done in UK and it's available. And what we understand, due to the short supply of vaccine, we will not get Pfizer vaccine within this month, but definitely from what we hear that in July, we will get Pfizer vaccine, at least 500,000. That is what I was told. So that is there, but within a week or two, those who have got the first dose of AstraZeneca will get a very clear instruction what to do. That is what I understand. I think that will settle. The Sinopharm vaccine, the duration of the second dose is for 4 weeks, and the next 1 million is, as far as I know, in reaching on 6, and possibly another 1 million within a week's time. Sputnik, there is a controversy. I know I will address it because this is a scientific community mainly. Sputnik, there are 2 doses to be given. First dose is different from the second dose. These are 2 separate doses getting, 2 separate manufactured doses. So there is a problem at the moment, what we understand, but fully details are not available till. The second dose of Sputnik, we have not still got. And what we understand, there is an issue on the production line, but I don't have exact details. So the first dose of Sputnik has been given, and it enhances some protection. That is the initial data says. So when you get first dose of Sputnik, after about 2 to 3 weeks, you will get some amount of protection. But now studies are being carried out to see whether you go along couple of more weeks, whether it will have an effect or not. So the final data is still not available. So that is the case. And I think I heard from the SPC that they are still looking for the second dose. So the time would state what is going to tell. In the scientific forum, I'm not going to give predictions. Sinopharm vaccine, we have to be very clear. From the first vaccine, we will have very little protection or no protection at all. Generally, Sinopharm first dose to second dose, 4 weeks. After 4 weeks, you have to give the second dose, and only about 3 to 4 weeks after the second dose that you will develop your immunity. So after the first dose of Sinopharm, you are not immunized. This is the thing. The second dose of the Sinopharm of the first round will start on 8th, and the notice will come possibly by end of this week. Thank you.
Thank you. We are hopeful to get the second dose very soon in Sri Lanka. Thank you. The next question is: some believe that the injection of 2 doses of vaccines, non-pharmaceutical interventions, for example, wearing face masks, is required. It is also believed that with 2 doses of vaccines, one cannot get infected at all. Could you agree or debunk these 2 notions?
As I told you at the very beginning, vaccination is one of the public health measures. It is not the ultimate method, because all these vaccines and their immunity and efficacy has been studied for a very short period of time. Because to develop a vaccine like this, it takes 10 years or so, 8 to 10 years. This, we have reduced the timeline to go through all the steps. They have gone through all the steps, but with a reduced timeline. So their way of analyzing it for long term is through mathematical models. Therefore, we have to be very clear, the vaccines can basically, according to the manufacturers, according to the scientists, is to reduce severe disease and minimize deaths. Its impact on transmission would only start to play when at least 70 to 80% of the population is immunized, where the others would be not getting the infection from others because majority are immunized. Till at least 70% to 80% in immunized in the population, you need to go for other public health measures that we have been advocating throughout.
Thank you. The next question is also about the myths of vaccination. There are so many, schools of thoughts coming up. So it says, even with the administration of the COVID-19 vaccine to a person who recovered from the disease, there may be a risk of catching the disease once again. Do you agree with the statement? If yes, explain how does it occur? And also I will read the others as well so that you can answer all together. How long does the vaccination protect us against the COVID-19? Or in other words, yearly do we have to, get this injected? Is there a possibility of vaccine-induced mRNA to change human DNA by penetrating into the human cell nucleus? After the administration of vaccine, some said that they have no signs and symptoms appear. Does it mean that the vaccine shots administered are of no use?
First one, I think, is mixing of vaccines. I basically have answered that question. There are very limited studies where mixing has happened in UK and few other places. Therefore, the evidence is there for one vaccine, which is AstraZeneca and Pfizer. And the new studies are being tried, and some data would come possibly in next couple of weeks of particular AstraZeneca and Sputnik. even in Sri Lanka, there's a basic study is been planned. That is one. Second question is, there are so many questions. Last one I can remember, whether this genome could change whatever.
DNA.
Yeah. The issue is, I think these are recombinant things where close monitoring has been done, and none of these vaccines came from sky. The basis for these vaccines have been researched for many years. What they have done is they have adapted these to the current situation of SARS-CoV-2. These basic structures of those vaccines and the genome and those principles have been tested for some time. So there is no evidence at the moment to say that it will change whatever the genome. There was one other question I missed.
That is, say for example, if you don't get any signs and symptoms after the first shot, or let's say second, does it mean that the vaccines are not going to be used?
No, I don't think. If you think, for example, how do you feel pain? Professor Jayaveera will find some pain, you can tolerate, but I will then the same thing not tolerate. And I would react to something in a different way from other. All of us are unique. And how you respond to the first dose or the second dose will not determine whether your inside bodily mechanisms would generate adequate immunity or not. I don't think that that notion should go, because people think when they go to certain vaccines, nothing happens. Of course, for some people, they ever get admitted. It's the same. If you get attacked with whatever of insect or whatever, somebody gets huge reaction, somebody don't get. So it does not mean that you got that whatever the issue on you. So I don't think that understanding should go any further.
Okay, thank you. And also, people are a bit, scared of certain complications of COVID-19. For example, it says general public in the recent past seems to have heard another consequence of COVID-19 disease, making patients suffer from more complications to rapid death. This complication is called cytokine storm. What is this all about? Will this phenomenon be another fast track to the death of the COVID-19 patients?
What I heard, I am not an immunologist. First thing I have to tell it very clearly. From my basic knowledge, I am answering this question. There are immune mediators within a person's body. And when an insult is made to the body, those mediators are released from cells to the blood and the other systems. And these mediators have their own way of working within the body, and different people react in different ways. This is what is going to make different systems homeostasis or the balance get out of control. So there is a truth, because this cytokine storm is what most of the people are, or the physicians are trying to control when patients is admitted, if they suspect it. And these mediators are what make changes in your body, different systems, and make you rather unhealthy, make you severe, and so on. So that is a reaction every one of us have, but for different degrees.
Yeah, okay, thank you. The next question is, what is everybody is, very eager to, know as far as today is concerned. The question is, some experts involved in the COVID-19 pandemic, including Professor Malik Peiris, one of the renowned virologists, reiterate that the lockdown for 14 days imperative and is a must when Sri Lanka is found to have COVID-19 casualties reaching more than what hospitals could manage. For example, let's say more than 2,000 per day, to flatten the rising case numbers. However, this magical phrase, within brackets, I say lockdown for 14 days, is tied up with generation time, incubation period, infective period, and serial interval of COVID-19 virus. Could you explain what are these time periods and how do they help transmit the disease? Secondly, is there a science-based evidence to support this request on lockdown for 14 days to bring back the normalcy in the country?
Yes, this is what I need to tell. On 21st April night, I can tell it because I was part of the people who did the proposal to send on 22nd morning. Late night till 21st of April, when we saw the rise of this, we asked for an immediate lockdown of 14 days. And definitely, we asked for on 14th, looking at the number of cases at that particular time, which was about 19th of April, which was coming up to about 600 cases, right? Why we asked it? And what Professor Malik Piris came in public in a webinar that we coordinated about 2 weeks back. And the rationale is this. And Professor Malik Piris knows exactly the incubation period of SARS-CoV-2. He is one of the eminent scientists in the world to tell you that anyone else in this country, anyone else, most of people in the world at the moment. Why he says the time of getting infected from a SARS-CoV virus to get the disease, they have calculated the basic work actually at the very beginning, I think, was done also in Professor Malik Piris' lab in Hong Kong. They saw that it takes about 2 to 14 days for the incubation, where the virus gets into a body and try to get you sick. And that period is called the incubation period. That is why we are talking about 14 days. But there has been exceptions in certain people who have gone to about 28 days, but very exceptions. But the general is 14 days. So why people ask for 14 days is, if we have a caseload today, and if we have a lockdown today, and lockdown means movement restrictions and to a very maximum restriction, which means people who are having that disease inside, but who are not actually transmitting to others, will be in a, I would rather say, in a bunker, at their own home. And they are not spreading for anyone else, but maybe to on people at home. So when we can keep people in a place, reducing the mobility as far as possible, the possibility of getting that to others will be definitely reduced. That is the basically whatever the science behind keeping 14 days. But when your number of cases have gone past a given threshold, the 14 days may not be enough. I'll explain because this is extremely important. I don't know how many of you know the lockdown, if you want to get, have been extended by 7 days after a meeting today. So I know the details. So it was extended up to 14 days, 7 more days. So the issue is that when it comes to a certain level of infection, even if you lock down for 14 days, there has been spread of things which cannot be controlled by only one incubation period. Then you may have to have at least 2 incubation periods to keep them inside and get the infected out to the hospitals, treat them, and make sure they are not going outside without knowing they are infected and doing their general business. So generally, what I personally feel, to do this particular lockdown, we need at least 28 days or 2 cycles. But you can't ask for 2 cycles at the beginning. You know how people, the decision makers, would feel. That is why we ask for 14 days first. Now there is a 7-day extension. And even if you have 14 days from 21st of May up to June 7th, you will not see a reduction of cases by June 10th. You will still see that case coming because these are cases that are appearing on the early 20s of May, where spread is still going on. So to get an impact on the issue, you will see another 2 weeks to going that you will see a reduction of cases. And if you look at deaths lag even 1 week to 10 days behind the increase of cases. So the deaths would be recorded higher numbers by end of second week of June.
Thank you. I don't want to put you into trouble asking about the government stance on this. Let's move to the next question. Transmission of the SARS-CoV-2 via fecal oral route is getting serious attention after the viral RNA has been detected in the stool samples of the infected patients. It has also been suggested that the virus persists longer in the digestive tract than the respiratory tract. Don't you think that we are in great danger if these sentiments are true? Please elaborate your opinion on this.
I think almost 6 or 7 months back, this digestive and fecal-oral route hypothesis came in when they found, I think, isolated fecal virus in fecal matter. I can't remember the exact place, but this came up. But up to now, as far as I can see, we have not seen proved cases of infection through that route. And I personally feel it will be very difficult to prove, because there will be multiple things you can single out and tell that it will go through orophycal route. But if you look at how the spread is going across, it's very unlikely the major contribution, even if it is true, through fecus, but it's through respiratory way. That is the thing I can tell, because I have not seen hard evidence on this.
Okay, thank you. The next question is where even the WHO speculates, a very important question for you. In the middle of 2020, some expert experimented with the use of an anti-malarial drug called hydrochloroquine for COVID-19 patients. The controversial paper on the hydrochloroquine or chloroquine with or without macrolides for treatment of COVID-19, a multinational registry analysis, appeared on the Lancet, has corroborated an increased risk for COVID-19 deaths. Just after the emergence of this paper, the WHO suspended all efforts of experimenting with hydrochloroquine clinical studies. However, after a few days of publishing, the authors have retracted this paper as they could not prove the authenticity of the big data used. What have you got to say about the use of hydrochloroquine for COVID-19 hospitalized patients in Sri Lanka?
What I can tell is I am not a physician who is treating in the hospital. Therefore, my understanding will be limited. But referring to the paper that you had mentioned, at this particular moment, we have to be a bit cautious about the scientific literature coming through, even through respected journals. I think for 150 years or I think 170 years of history, the Lancet has to withdraw that paper when they finally found, and the Australian doctors very clearly claimed that they never had such numbers in their hospitals. That was the case. And in Sri Lanka, when it was actually published, two of us in the middle of the night over the phone was looking at the paper, and we were also not really clear how much 96,000 was in the treatment or the I think control arm. And looking at those data, we were also questioning, were such numbers in some of those hospitals that they were referring to. So my portion is, I'm a bit cautious looking at even scientific papers at the moment which are appearing in and major journals, because some of those are funded by interest groups and industry. That is one. The question that you are asking, there has been a trial in Sri Lanka using this, but I'm not sure about the final analysis. But in Sri Lankan hospitals, this drug was used. For that I know. But from the evidence we have, most of the drugs which has been certified for emergency use for COVID, even antivirals, now proven to be not much useful.
Thank you. The next question is also something, another alarming phenomenon that is basically going viral these days. Another COVID-19 related consequence known as COVID tongue has been articulated by many in social media. Enlarging the tongue by a few centimeters causes this phenomenon, and it may be regarded as the COVID-19 after effect. It is a true consequence of COVID-19. If so, what is the science behind this effect? What have you got to say?
I am actually extremely sorry on this question because I have not looked at any literature, because if real scientific literature comes on this, it is generally circulated among our circle. I am not sure about it and I don't want to comment on it because I have not looked at it. Sorry that I can't give a clear answer on this.
Thank you, because it's going to be very difficult even for us to, find any evidence from the respected journals. As you rightly point out, we'll have to wait for some, maybe couple of days. Let's go to the next question. Some members of the medical fraternity in the country, through genomic sequencing overlaid on epidemiological data, disclosed that the B1411 lineage Sri Lankan variant was predominantly prevalent in Sri Lanka from early October 2020 to the end of second wave in March 2021. However, with the onset of third wave in the mid-April 2021, the UK or the Kent variant B117 has been dominant up until today. Some experts believe that this transformation was merely due to the country's opening up for the foreign visitors, particularly to Ukrainians. In your opinion, who was at fault? Was it the government or health officials in the governing committees of the COVID-19 who is at the fault? What is your opinion?
Yeah, actually, if you look at variant and what's happening country, we need to look at, we have one lab doing genomic sequence of these viruses with very limited facilities, and they are doing a good job. There's no doubt about it. Jardalpura, they are doing an excellent job. Otherwise, we would not have known any of those here unless we have sent samples outside. However, from looking from epidemiological and public health angle, if we are going to tell that something is dominant, then we clearly need to get a representative sample of patients across the country, across different segments, and do a fairly large number of samples for genomic sequence to tell whether this is the dominant or not. But most of the time, due to resource constraints, these are highly costly business, there has been few samples tested, but they have found certain variation. So I'm not really sure how I think I would rather say possible in the epidemiological way to tell whether this is dominant and other is not dominant, and the dominance is taken by another variant after a certain time, without doing a population-based genomic sampling of cases. And unless we will only say that we see certain variants, and that is also good data that we have. But I'm not really sure how can we tell that this is dominant in this era, this is dominant in this era, and this is dominant in this era without doing a representative sample of viruses from patients across the country.
Thank you for your clarification. The next one is, given the high rate of infectivity, transmissibility, and severity of the SARS-CoV-2 variants, the WHO has declared that some, for example, UK, Brazil, and Indian variants are variants of concern for global civilians. Many believe that these variants of global concern evade antibodies produced by vaccines by substantial percentages. Does it mean that the vaccination is not a solution for the COVID-19 pandemic? Or do we have to live with the COVID-19 for many more months? What is your opinion?
Now, for the sake of convenience, these three variants have been actually designated as yesterday: Beta, beta, alpha, and alpha, beta, and delta. Basically, those three variants. The issue is because there is a variant coming and the pattern of its spread is different, it generally becomes a concern across the world. That is one. Second one is when the initial stages, when the vaccines was developed, it was done using one or two strains which were prevalent at that time when the research was done. Therefore, there is enough, I would rather say enough concern that will that base of vaccine would be effective against generating immunity for variants. This is the concern. Now, what they are telling in new evidence, basically preliminary and intermediate analysis that is coming, certain vaccines can cover most of those, but to some extent. For example, if we think for the earliest variation or variant, if you have 94% of Pfizer immunity, maybe for a later variant, it could drop to about 60 or 70. Which means if this is going to prolong for long, there need to be boosters coming in periodic intervals. For example, in Western Hemisphere, basically, in the fall, you will be administered a flu shot every year for particularly people who are over 60 and so on. Why? Those cold viruses, influenza viruses mutate very rapidly. So this year, the injection will not focus next year. So they study this and they give it. So there is a possibility we may be heading to that. That is why I saw few news items and others from Pfizer and even AstraZeneca. I think they are looking whether it's necessary and it can be a reality. And if that happens, and I think countries like us will suffer more.
Okay, thank you. Let's hope that it will not happen. Next question is, Professor Malik Piris in a recent dialogue has mentioned that the Indian variant B1617 has been confirmed twice in Colombo with the genomic sequencing carried out by the group of scientists from Sri Jawaharlal University. People have now been engulfed in fear that the Sri Lanka will be experiencing a similar bizarre situation as India did. Also, some are highly speculative on the rise of mucormycosis, or you call it black fungal infection after the COVID-19, like in India, even in Sri Lanka. What have you got to say about these two issues?
Basically, looking at, we will try to finish it quickly. Looking at this black fungus, this business, it came as a detection of a patient in Ampar hospital, but later it was very clearly stated that that person's issue was a separate issue, and he has been now treated, and he has, I think, but he died later. But it was a separate issue. It is not very clearly stated by clinicians. It is nothing to do with COVID. And black fungus, that particular disease, I think that these dermatologists and other microbiologists very clearly state it is there in this country and they see certain cases every year. So it's not a new thing to this country. But up to now, I don't think that we have detected anything as a sequelae of COVID as having black fungus. But it's a serious disease which you need much attention and serious treatment. But as far as I understand from those colleagues, we have drugs and we have treatment modalities, protocols treating. So I don't think that at this particular moment we should worry.
Okay, so we'll now come to the last question. The 19th is almost, you have answers, so that I just want to skip it. Let's begin with the last question, number 20th. Some believe that the novel variant with exorbitantly high transmissibility and severity may emerge from the present lineages, resulting in millions of casualties. What are the chances for such great havoc to take place? What are we doing currently to avert such situations occurring? Why does Sri Lanka not enhance the genomic sequencing of casualties to capture the variant transformation taking place? Importantly, why are such genomic data not disclosed to other experts? Over to you, sir.
Yeah, I think, as I told you very clearly, there's one laboratory who is doing it at the moment. And our human resources are extremely limited on this front. And to do such things, you need the equipment, you need certain assays and so on. So what they are doing at the moment at Jardurapura is commendable. There's no doubt about it. If they were not there, we would not have known any of those. That is one. Second one, the variants can occur. You see, well, now we see another variant that is been detected, but less information is there, scientific information in Vietnam. Vietnam was a country which was really well controlling COVID. But now there is a so-called variant there, which they say is a hybrid variant of Indian and UK, both. And we still don't have much information about its transmissibility, virulence, and so on. So it can happen. I don't think I don't discard it. It can happen, but we need to also understand majority of the variants that come from a virus are harmful to the virus survival. Therefore, most of the variants that happen in this genomic sequence will kill the virus itself, and it will not go beyond that. But there are instances, few come time to time periodically and become serious public health issues. That is how things work. I am not in a position to tell or predict, but it is like a scientific fiction that we have to think about. There are a few films which are very similar to what we are seeing. Even there is an Indian film of virus. I think it's Malayali film or whatever, which is looking at what we are seeing now. So this is fiction. But what I want to tell very clearly is we need to make sure that our control strategies are going on well. For example, I am very clear, I am advocating that we need to immunize population up to 70%. At least when we have started the Western province has to get the maximum and try to finish off, particularly over 60 years. Then you can minimize deaths, then 30 to 60 years and others, then you could prevent these kind of things coming in. If you just trying to vaccinate here and there all over the country, then the immunity pockets will be there within large areas of non-immune population, which would be somewhat a platform for certain variants to occur. So that is the danger that I am pointing here.